Okay, so next is acute kidney injury. It's V2 from critical care and anesthesia. So you have been asked to review a 72-year-old male who is day 5 post-op following a left hemicolectomy. His heart rate is 90 beats per minute, his blood pressure is normal, and he is aperaxial. His urine output has deteriorated in the last 6 hours, and in the past 3 hours it has been less than 0.10 ml per hour. How will you manage this patient? So this patient is oliguric. The commonest cause is post-op is hypovolemia. So I will ask from the patient about his thirst, any pain, any shortness of breath. I will examine the patient about his hydration status, signs of heart failure, sepsis, periodism, and asthmatic leak. Review the observation, fluid chart, drug chart. Look at the medical notes like comorbidities, operation, note and previous renal failure. Then I will check out the blood count, urea electrolytes trends, electrolytes, and request use, and will look at the urine. The patient is not obviously septic. He has 500 ml of IV saline today and is not really eating and drinking yet. You think he might have an acute kidney injury? How do you define acute kidney injury? Is rise in the serum creatinine more than 26.5 micromole in the 48 hours, or more than 50% from the baseline in the last 7 days, or urine output of less than 0.5 mil per kg per hour for more than 6 hours. So this is the most recent definition of AKI from the kidney disease. What are the common causes of acute kidney injury? So prerenal, renal, and postrenal. In the prerenal, there is a loss of blood, loss of fluid. Loss of blood means hemorrhage from anemia. Loss of fluid means hypovolemia, diarrhea and vomiting, third space loss, pancreatitis, burns, septic shock, patient dehydration, and pump failure, cardiogenic shock, MI, acute coronary syndrome. And renal failure, intrinsic renal failure due to glomerulonephritis, interstitial nephritis, or acute tubular necrosis, and post-renal obstruction of the flow of the both kidneys at kidney pelvic level to ureter to bladder to urethra. So you thought the patient was dehydrated and gave 500 ml of fluid challenge. His hydration status has improved, but he remains oliguric. His chest X-ray demonstrated that he has developed some atelectasis since he came back to the ward. Now what will you do? So firstly, check is there any nephrotoxic drugs going on. No obvious cause. Rule out any sepsis and block catheter MI that can be treated, and then liaise with the nephrologist and ITU ongoing support while treating the cause. Patient may need central line monitoring to monitor the fluid station. If he's still oliguric despite his being adequately filled, cell surveillance pressure is more than 8, he will need either an inotropic dobutamine or a vasopressor, noradrenaline, to optimize the cardiac output and improve the renal perfusion. One of your juniors prescribe another liter of fluid. The patient is taken to HDU and a central line recorded CVP of 18 millimeter of mercury. He is now shortness of breath, his respiratory rate has increased, and he remains oliguric. How would this change your management? So the dyspnea and elevated central venous pressure suggest that the patient is now fluid overload with acute pulmonary edema. Further decrease the renal perfusion. His acute injury has probably been triggered by the sepsis. As the patient has day 5, likely the cause is an asthmatic leak. Other causes include chest infection, wound infection, ciliary site infection, or site infection. I would like a CT scan to confirm the diagnosis, but the IV contrast could worsen. He now is likely to require a renal replacement therapy. Can you determine if he is still in reversible renal failure or has developed the intrinsic renal damage? Yes. So we have to check the urine sodium, urine osmolarity, and urine plasma urea ratio, and fractional excretion of sodium and fractional excretion of urea. So in prerenal failure, the kidney function is preserved, therefore urea excretion and sodium preservation are possible. Urinary sodium osmolarity in urine muscular will help to diagnose. So prerenal failure, urinary sodium is because kidney is working, so urine will be less, no loss. So urinary sodium less than 20, urine osmolarity more than 500, urine plasma ratio more than 20, and microscopy normal, and fractional excretion of sodium less than 1% is normal, and fractional excretion of urea less than 35%. And in renal failure, urine osmolarity will be more than 40, urine osmolarity will be less, urine plasma ratio will be less, microscopy will show the cause, and fractional sodium will go to 2%, and fractional urea will go to 50%. What is pathophysiology of tubular necrosis? So because medulla is the more sensitive to the ischemia in the kidneys, and kidney receive 20% of the cardiac output from the heart. In case of drop in the perfusion lead to the decreased sodium reabsorption, this causes arteriolar constriction and a drop in GFR. The ischemic cells swell, causing cytokine activation and resulting in acute tubular necrosis. The anuric phase of the acute tubular necrosis classically lasts 7 to 21 days. Once renal perfusion and oxygen supply are restored, viable cells still adherent to the tubular basement membrane and spread to cover the denuded areas. Um, that they reproduce normal tubular architecture and function. A polyuric phase will follow when glomerular filtration has normalized. The kidneys may eventually regain full normal function. Before requesting the CT scan, you check the latest blood test. The patient potassium is 7.3. How will you treat this? So first of all, ask for an urgent ECG and prescribing the necessary drugs. So ECG will be showing the tall tentative absent pupils in broad curious complex, and I will give the patient 10 ml of calcium chloride 10% over 10 minutes. Then I will give the patient 10 units of insulin and 50 milliliter of saline with 50 milliliter of 50% dextrose. Then I will give 10 milligram salbutamol, and then I will give sodium bicarbonate, and for removing the pressure on the body, I will give calcium resonium and stop the potassium sparing diuretics. Furosemide may be given, and patient may need renal replacement therapy, and hemodialysis is more effective than the hemofiltration. What are the indications for renal replacement therapy? Pericarditis, encephalopathy, uremia, symptomatic uremia or uremic encephalopathy, and pericarditis. Metabolic acidosis, pH less than 7.1, unresponsive to medical therapy. Severe hyperkalemia, unresponsive to medical therapy. Pulmonary edema, not responsive to medical treatment. Poisoning, high urea creatinine, relative indication. What are the types of renal replacement therapy? So hemofiltration, when the patient is fluid related, they need hemofiltration, and blood is pumped through a semi-permeable membrane, and the hydrostatic pressure on the blood side of the filter drives plasma water across the filter. Ultrafiltration, and small molecule sodium, urea, bicarbonate, creatinine are dragged across the membrane with the water by convection, and the filtered fluid is discarded and replaced with the fluid buffered with the bicarbonate and lactate. And the other method is hemodialysis. Blood is pumped through a dialyzer. In the dialyzer, blood is separated from a crystallized solution by a semi-permeable membrane, and the solute moves across the membrane along their concentration gradient from one compartment to other. Bicarbonate moves from the dialyzed site to the blood. Urea and potassium move from the blood to dialyzed site. To maintain the concentration gradient, dialyzed site flows counter to the flow of the blood. When removal of the water is required, the pressure on the blood side of the membrane has to be increased, forcing water molecule to pass into the dialyte. Thank you.